Thank you, Dr. McNeil, for that introduction. Just a little caveat about myself before I begin. I spent 7 years in the workforce before coming to medical school. I was 6 years in the defense industry and then 1 year working for the state of New York. So I bring a slightly different perspective than the typical medical student. I'm not sure if that actually matters, but it certainly will reflect on the way I experienced medical school here at Pitt. I think everybody here, whether you're a physician or a scientist, has dealt with the academic rigors that medical students face on a daily basis in your own lifetime. And depending on how long ago that is, you might have forgotten, thankfully, of how difficult that might have been. But in any case, I wanted to remind you of the world that the medical student faces on a daily basis and how it shapes the truly master educator. I think all of you have empirical evidence that Pitt Med students are highly motivated. I think that's by virtue of the selection process to get here. Every student has to be a type A personality. You might have some type Bs, but they're really just type As who are masquerading around as type As who are masquerading around as type Bs, or just As who have slight B tendencies. But at the end of the day, they all hustle, and that's how they got here. So I want you to consider just a thought experiment. If there were no formal instruction at Pitt Med, just curriculum and endpoints, so like course notes, lectures, but no actual instruction. So you might say, these are the learning objectives, which is what we have already. So maybe understand this organ or understand the mechanism of action for this drug. This group of self-starters would figure it out for themselves with the resources that are available. And that, I think, is a testament to how highly motivated they are. So I want you to consider, and this is a key point, the resources that are available today in 2015. So I went to undergrad about a dozen years ago, and we had textbooks and course notes and what I consider a rather lousy internet. So YouTube was still mainly cat videos. Khan was tutoring his niece but didn't have an academy yet. And Wikipedia was in its infancy. My alma mater, the University of Illinois, had a Wikipedia page about this big, okay, just to give you an idea. So I do realize for those of you who went to school before the internet, having lousy internet is better than no internet. But I think that speaks volumes to the fact that today we have a plethora of choices, robust choices, if course notes and textbooks are inadequate. So let me get to the meat and potatoes here. Streamlining. The excellent educator today, with the technology that's available and the motivation of these students, cannot be excellent solely by being a purveyor of didactic instruction. That ship sails with Wikipedia and all the other major resources I mentioned. So there are two things that make a great basic science educator in medical school today. With all the resources that are available, it can become too much. If you take the type A personality and you take this learning buffet that we have, it becomes too easy to waste time finding great resources and stuffing yourself unnecessarily with the samples before you figure out what's actually a great resource. So there are three things I say within that. Purposeful course notes. And what I mean by purposeful course notes, it's the idea that you're somewhere between first aid and somewhere between a textbook. First aid's really not enough to learn as a primary source of information, and a textbook's way too long at this point. You're really considering the time efficiency and also being conducive to learning. Now, this is actually what has happened. I say this with 100% truth. There have been instances where the course notes are only 4 pages long. It's literally just a list of facts. And the problem with that is it's kind of hard to learn something when there's no context. You're just memorizing 400 names or something like that. And that's not that helpful. The other side of it is when you have 50 pages of full paragraph upon paragraph of notes. Well, that approaches a textbook. If that's the case, students are going to say, why don't I just read the textbook? So it has to be somewhere reasonably in between that. And I ask you, this is like the smell test, more or less. If you didn't know your own material, how long would it take you to read through the lecture notes and actually learn it? Second part of that is PowerPoints that are supplemental. And the best example of this, Dr. Duker's here, is histology. Histology, you need to have pictures, and that's a great example. Literally, her PowerPoints are examples of what we're reading in the notes. So you have your notes out, and then you look up. There are other professors who do it with graphs, for instance. That's like the best mating of these two things, of the PowerPoint and the course notes. But there have been instances where the course notes and the lecture notes don't have anything to do with each other. So it's like they're two different sources. That's not helpful. At its very least, that's not helpful. And if it's more than that, it might even be considered just lazy, I would say. And the third thing I would say there is targeted resources from the outside. Because you have all these videos, all these online resources, something that you find, for instance, a subject that's typically hard for students, maybe include some online resources related to that. But I think that's really all you have to do, those three things, to be a great educator. I know this is a little bit more. I'll give it to you. This is not just an institution that creates great clinical educators. The point is to create great clinical educators who are also research focused. So at the very least, you have some research competencies, and more than that, you hopefully do some research. Khan Academy, Wikipedia, and all these traditional tech books are not going to devote much time to research, really, especially not the latest research. That's really something that maybe like Up to Date or the journals do really well. But the master educators at Pitt Med do that. Dr. Lance Jones does that. All her PowerPoints will always have, what are we doing in the latest area? What did the research show? What did the old research show? And she'll always have the links at the bottom. And I think that that's really important. In an era where information is cheap and plentiful, she's actually able to provide us with refined, less available information. And in doing that, the basic science educators are doing more than just feeding information to us. They're actually seeding a thought process. So Johnny, at the end of the day, knows more than just the facts. Johnny also understands how he can improve upon the process. Now, I'm a second-year student. I really don't have that much clinical experience, but I do have a little bit just from our Introduction to Physical Exam and AP. And it happens to be I actually had Dr. Grau as my facilitator. So I can just mention a quick thing. You know, we're often told to read Bates before we go to physical exam. And I think that's like telling somebody to read a dictionary or read an encyclopedia, because Bates is an awesome reference. It's very comprehensive. But I've actually tried to do this, and it takes like 5 hours to read one chapter. And that's just not possible with the time that we have. But this is where Dr. McNeil is great, because Dr. McNeil actually takes the time to produce PowerPoints that are an abridged version of what we do, what's in Bates. And that, to me, makes total sense. There was a fourth year last year who said that's the best part about this. Someone has actually taken the time to condense it for you, considering the time you don't have. And you can certainly watch videos to learn about physical exam, and that's pretty good. But ultimately, it's the hands-on training that ultimately, that makes the difference, if you will. And as I said, I had the privilege of being a student of Dr. Grau's, and what I thought was awesome with what he did. Typically, most AP facilitators will just say, so what questions do you have? And they'll just watch you, and that's really it. And I wasn't sure if it's because he was a colonel in the Air Force. My father was in the military, and this sort of reminds me of my dad. He actually inspected us. He asked, let me see you take a blood pressure. And there were 4 of us, and he watched each of us take blood pressures on the others, and then said, what are you doing right and what are you doing wrong? And he went through and told us. Now think about this. The ultimate assessment of AP is a CSA, a 108-point, test. When has anyone ever said, you're doing this right or doing this wrong? They've only said, do you have any questions? Now, he can't obviously do that for the whole thing, but he did that in that one example. I thought that was fantastic. There was another thing he did, and this caught me off guard at first. He said, so what do you do if your patient's obese and you have to measure blood pressure? Like, how are you going to do that if the cuff isn't big enough? So we're like, we're thinking he just wants an answer. He's like, no, physically show me what you would do. And of course, the answer was there's a larger cuff. You have to pull it out, put the other cuff in. But again, this is like drilling. But that's really important when your assessment's ultimately based on whether you can do the job correctly. So that's my brief feedback that I'd like to give you. I hope that's helpful.
Thanks, Sheldon. It's good. So there's some parallels between what each of us said, but I'm going to take a little bit more how-to or practical approach to how to be a good teacher or what makes a good teacher. So first of all, like Alvin, I started this, or began to think about this talk, and one of the first things that really struck me was the huge amount of material that's available. Okay, when it comes to resources for learning about learning in medical school. And a teacher's only one of those. There are amazingly well edited books and review articles with fantastic schematics and images. They're brief and to the point explanations, more fantastic schematics. Okay? They're videos, including lectures from superstars. I was really amazed to find a phenomenal lecture by probably the world's premier embryologist who happens to be in France, but giving an overview of embryology. It was beautiful, something I could never do. Okay, there, as Alvin mentioned, Khan Academy videos, and of course, a whole array of YouTube videos or other ones. The other thing you can ask, or what this sort of prompts you to ask, is whether a medical student even needs a teacher, okay? Medical students have years of experience with their own learning styles and what works for them, okay? They're smart, and they also have severe time constraints. Now, as a teacher of first or second year students, I also would ask if medical students need a teacher for basic science material, okay? They had to know it for the MCAT, or at least a large percentage of it. Okay, so in thinking about these facts or observations, I was then led to the following question. So, what are the critical elements that the presence of an actual flesh and blood human being, okay, really provide? So one of the most obvious or straightforward answers is that an actual human being can and should interact with students. A good teacher does this. Some of the best teachers that I've watched are intensively aware of student reactions to what they say. They demonstrate, in other words, moment-to-moment awareness of what's going on in their audience. It's like a improv actor would say. They read the crowd. In a practical sense, what does this mean that a good teacher actually does? A good teacher looks for and responds to questions and is capable of changing in midstream to restate a complicated concept when needed. A good teacher doesn't pack too much in, all right? If lecturing, they plan time for questions. If they're leading a small group discussion, they deliberately include pauses that encourage students to ask a question or give them a chance to formulate a question. When I was in school, I often thought, now wait a minute, I want to ask a question, but I can't quite get it together quickly enough. Oops, and now the time's gone. So give the student that time. A good teacher tries to read the audience and understand human nature. Know what's going on in the student's life. Did the students just have a test? Are they about to have a test? Is it the end of a long year? Are they about to be served pizza for lunch for the 100th time? If you don't know this, you and the teacher, can lose the vital connection with the student's frame of mind. At the very least, you could be confused by their behavior. Okay, a good teacher also recognizes that the audience is diverse with respect to backgrounds and interests. A student with a background in engineering not going to have any trouble with kidney mechanics. A student with a background in business or literature may be confused, frustrated, and or bored. Okay? Dealing with this diversity may mean passing over questions that are too sophisticated for the moment or off topic, or gently deferring questions that will take too much time to answer. Okay? A second critical element that a good teacher provides is motivation. Okay? Think about it as leveraging student interest. So what do I mean by this? The best analogy I could come up with is jujitsu. Okay? Jujitsu was developed as a method for defeating the armed and very heavily armored samurai of Japan with little or no weapons. Okay? It involved manipulating the opponent's force against himself rather than directly opposing that opponent's force, using leverage and the opponent's own weight, for example, to flip them onto the ground. In planning a presentation, a good teacher thinks about leveraging student interest to capture their attention and motivate them to focus. So what's this mean that a good teacher actually does? So first, they provide clear and explicit explanations for why something should be important to them. For a basic scientist, this is usually clinical relevance to the best of their ability. Okay. Also, you can let a story unfold with some kind of suspense. Begin by presenting a question or a patient story. You want to also get the students on your side. If you're short on your preparation time for that lecture or discussion, just make sure your beginning is really good. Change it up to maintain engagement. Add a question, again, for students to try, or try and answer, or switch from a PowerPoint to a chalkboard. Use analogies. Choose something familiar and something emotionally compelling, something that resonates with the student's past experience or interest. For example, in the neuroscience course, Dr. Knickie talks about the neural origins and neural circuitry of headache. But he also describes the feel of a headache, how it starts, how it influences daily life, things that everybody can relate to. Now, you might say, hey, that's unfair. Headache's a really easy topic for everybody to understand. The important thing that Dr. Knickie did is that he takes the time to actually do this in the lecture. Okay. Move your discussion or presentation away from being a pile of nouns. Okay? Describe things as actions rather than putting labels on. Rely on verbs, okay, rather than nouns. Don't say, or I hope I don't say, just that the spinal cord comes from the neural tube. Show them the process. Talk about cells moving. Okay, now while moment-to-moment awareness and the ability to motivate are really important characteristics of a good teacher, all the awareness and motivation in the world will go out the window if what you're saying isn't clear. Any student wants to believe that a teacher's presence and presentation are going to help. Let me give you a personal example or comparison. I get very frustrated with computers and my smartphone. I know I should read directions, try different commands. Now, I can be really patient. I can be very patient in examining embryos, but I'm impatient when it comes to my smartphone. I know I should be patient, but it's really an elusive goal, okay? I really appreciate it if somebody, and usually, in fact, this is a student, answers my question simply, helps me. Students want to be treated that way too. I began to say that there are wonderful written textbooks and materials out there, but these can be a problem too. Students can and have spent a lot of time switching from one website to another, or from one book to another, because the material appears too long, or too short, or it's too elementary, or it's too sophisticated. A first-year student once came to my office with Netter's anatomy book in hand. He opened it up to a page with an image that had about 30 labeled structures. And with some amount of frustration and real dismay, asked, how is he going to memorize all this? How is he to decide what was important? Okay? One of the most important jobs of a good teacher is to provide clarity and answers to this kind of question. So how do you do this? All right? First, curb your desire to talk about or discuss what you, the teacher, think is most interesting. Kathy Ryan and I were having breakfast a couple of days ago at Ritter's, and she told me of something that had in turn been relayed to her from an excellent teacher and ex-course director, Dr. John Cright. He was helping a faculty member repair a lecture, or the lecture notes, because the lecture had gone really badly. Okay? After simplifying the lecture notes a great deal, the faculty member was not happy. In fact, he was really dismayed and responded that the lecture was now really boring to him. Okay? In fact, the lecture was only boring to him because he knew all the background material and important concepts that the student didn't know. So, when giving a lecture, try to give a broad overview, a skeleton, that tells the student how to link a lot of facts or ideas or terms together. They will try to do this, in fact, in studying or in their own studying after the lecture. So give them a scaffold that will allow them to add details in the right place. Know, if you can, what came before and what will come after a teaching session, and present material at the appropriate level. Provide study or memorization tips. This is probably really important. Focus as much on how you explain something as on the subject itself. Be ready to stop and repeat a concept in a different way. I went last year to a lecture by Dr. Dan Simons in the Department of Neurobiology because he was retiring. And he had been getting really good lecture evaluations for years and years and years. Now, he's a really serious scientist, a serious guy who works on sensory systems and sensory circuitry. And in listening to his lectures, which went on for about 3 hours, it became clear to me that one of the things that he did in one way or another was repeat important concepts at least 3 times, or important terms. It was sort of hidden, but it was there. If you actually counted it up, everything important was said 3 times. Another thing that I think Alvin mentioned is that you should follow your nose, okay? It's really dismaying. It's dismaying to a faculty member to hear this massive fluttering of pages if you're lecturing, and it's obviously indicative of the frustration of the student as well, okay? They're trying to find where you've gone, okay? Keep notes as simple as possible. Remember that the student's really good at fleshing things out. Make sure your notes are well organized and free of mistakes. I've been really surprised by the fact that students get really thrown or get really cranky if even the smallest errors are there, okay? It's probably because students wonder if they're missing something. It obviously also has something to do with the pressure that they're under to accomplish a lot in a short period of time. In your talks or discussions or PowerPoints, highlight important concepts or construct and use a concept map. And lastly, be explicit about telling students when you're going to change a topic or shift gears. Okay. I think these topics that I've just talked about, awareness and motivation and clarity, are really the most important characteristics of a good teacher. But there are 2 other things that can be valuable, especially for medical students in the first and second years. The first is passion or enthusiasm. If you're enthusiastic about something, students will at least be curious to know why you're so enthusiastic. Enthusiasm also relays the idea that you want to be there, that you want to help them, that you think the topic of your discussion is important. If you seem indifferent, the student will react in an indifferent manner as well. Now, this doesn't mean you have to be bouncing off the walls. I've known a few people who can carry this off, but most of us can't. Just approach the task with this sense of challenge rather than routine. You could say something like, "This is going to be hard, but it's cool. Stop me if you didn't get it. It's important to me that you do get it." And last, or the second of these secondary things, is to know your own strengths and the strengths of other resources. You should be aware of what's on the web and relevant to the topic you're dealing with, and make suggestions for good web material, or in fact good chapters. Last, play to your own strengths. Are you better as a lecturer or a small group leader? Use the learning modality that works best for you. I know one faculty member who's exceptionally smart, but when he lectures, he goes way too fast, skipping over background. He loses the audience within about 10 minutes, okay? On the other hand, this same teacher is one of the very best small group leaders that I've worked with. In a small group setting, I'm not exactly sure why, he seems to forget about time constraints and takes the time to explain things. So as I said, this person really knows a lot. Here, his great knowledge base really works. Okay? So choose, if you can, what learning modality to use yourself. So that's where I am.
So I'm going to hold questions for our speakers till the end so that everybody has the opportunity. I think a lot of richness that has been already identified. We'll let Richard go, and then we'll go from there.
All right, I'm going to introduce my speaker. This is Richard, and I'll tell you how I've never worked with Richard, but I was sitting there and I said to Shanta knows all the fourth-year medical students, and I said, Shanta, could you tell me of a good fourth-year medical student that would be able to speak well on this topic and represent themselves to such a great group of educators? And Richard's name came right up. So that's his introduction, that Shanta knighted him as an excellent medical student. So Richard's going to talk about what it means to be a clinical, what he values in clinical teachers.
Good morning, everyone. For those of you who don't know me, my name is Richard Zoe. I'm a fourth-year medical student going to internal medicine. I'm very honored to be standing in front of such an impressive group of physician educators today to share my thoughts about the qualities of what a great clinical teacher represents. So reflecting on my very, very short academic career thus far at the University of Pittsburgh School of Medicine, many of my most memorable clinical experiences have, in some way, shape, or form, been impacted by wonderful physician educators. As you're aware, the transition from second year to third year of medical school is a period of time when the student begins to apply his mastery of the basic sciences to the clinically oriented patient-centered medicine that we see on the floors. This transition from the lecture hall to the patient bedside is quite an exciting time for us, but also a time filled with many unknowns and a lot of mistakes. Luckily, the majority of us have been fortunate to have been taught and guided by teachers who ease this transition. So what makes a great clinical teacher? Well, to be honest, many, many things. But for the purposes of today's talk, I will concentrate on just two. The first quality is enthusiasm. Similarly to what Dr. Lance Jones just said, I truly believe that at any level of teaching, the leader's mentality has a unique ability to shape and mold the overall team's attitude for the duration of their time together. For instance, I vividly remember my first day clinical rotations as a wide-eyed and quite nervous third-year student with a fresh new white coat stuffed with basically every piece of equipment imaginable. Within a few minutes of interacting with the attending physician, however, it became very evident that this was a clinician who was very passionate about teaching, which only made me more inquisitive as well as interactive throughout the duration of those 4 weeks together. As medical students, we look up to those who are excited to share their knowledge and who are passionate about their particular field. And it is therefore no surprise that in my personal experience, the attending physician's attitudes greatly reflect our overall interest and involvement. The second quality is time. Now, as a student, I can't even begin to fathom how busy your daily schedule must be, from clinical responsibilities to research obligations to family life and honestly everything in between. While it is infinitely easier for me to say these words than to actually act on them, the most exceptional attending physicians I had the pleasure of working with were those individuals who willingly dedicated time each day to their team. Whether this was in the form of formal teaching or small group sessions about patients or maybe even informal feedback, these actions not only provided us with more educational opportunities every day, but also promoted a sense of team unity for everyone. I've said this to my fellow classmates many times before. While this institution's ability to provide its medical students with broad-based clinical education through various formats, from learning at the bedside or in the operating room to small group sessions to online modules, it has been the faculty members that truly made the biggest difference. I consider myself fortunate to be earning my medical education from clinical educators such as yourselves. And as someone who is one day interested in academic medicine, it's my hope that I will share your same passion, education, and mentorship to future groups of medical students. Thank you.
All right, so I have PowerPoint slides. I know that's not a good educator, but it's my crutch. So I'm Tom Grau, and first I'd like to thank Missy, Roseanne, and Hollis for having such a seminar. I came from outside, from the military, and I was involved in medical education, but to have an opportunity to talk about faculty development once a week, you guys don't realize how special this is. There are very few places that have this, 1 week it's a talk on faculty development. Next it's medical education research techniques. It's just wonderful. And I know Roseanne is leaving, so is Hollis. But we're losing. But the idea of putting this up there is great, and it makes you guys better teachers, as I'm going to talk about in a second. Just the fact that you think about teaching on a regular basis. So, what I'm going to talk a little bit is what makes someone a good clinical teacher. That was my topic, although I really think it should be, I'm in the Air Force, and I was in the Air Force, and we believe in AIM high, so this should be great clinical teacher. But anyway, my topic was good, so I stuck with what I was given, because I follow orders. Anyway, I'll talk a little bit about insights from the medical literature. I'm going to talk about the Stanford Faculty Development Program. That's a program that I went through, and it's a framework for clinical teaching, and it has a lot of good information about what good teachers do. I'm going to talk about the concept of pedagogical content knowledge, and then I'll kind of talk about my views on effective clinical teaching, and hopefully give you some tips on how to improve as a clinical teacher. I think that's something we could all do. Okay, so I'll make this brief because I knew, being the last guy in a four-man thing, that I'd have minimal time. I had this wonderful Robin Williams thing to show you. It would have been wonderful, but anyway, it's not there.
Leave them wanting more, Tom.
That's right. That's right. Well, so anyway, there's a lot of articles in the medical education literature about what makes someone an effective teacher. Most of them were either essays on good teaching, or they used learner evaluations or surveys to identify effective teaching behavior. Interestingly, very few used outcomes. There is one article, which I'll show you in a sec, that used outcomes. And really, as you might imagine, what they found kind of depended on what their evaluation instrument looked like and what their questions were or what framework they used to decide it. But if you read through all these articles, and believe me, I read a lot of them, there's a few common themes that have come up, and those themes have already come up today. One is that effective teachers are enthusiastic. They're enthusiastic about their topic, they're enthusiastic about teaching, they're enthusiastic about learning. That comes up over and over again, and obviously Richard said it, Dr. Lance Jones said it, it's very, they're excellent clinicians, good clinical skills, good diagnostic skills. They have strong teaching skills, and the teaching skills that kind of float to the top are clarity. Again, Dr. Lance Jones mentioned that, organizing material, and involving learners. And they teach to the level of the learners. Now, these are the common themes that come from the surveys when they survey the medical students. And I would say that that's part of being an excellent teacher, but that's not all of being an excellent teacher. There were two things that really don't come up as much when you look at that literature. They come up in some articles, but not as much. And I bring these up because the educational literature and the cognitive psychology literature say these are very important things when you're looking at learning outcomes, and that's giving feedback effectively and setting high standards. And those are two things that we really see in the educational literature as affecting learner outcomes. Okay, this is an interesting article. This comes out of USHU, so a guy named Stuart Roop, who was a medical student when he did this. So you guys have now lectured on medical education. He actually wrote an article, so there's the high standard spot guy.
No pressure.
They evaluated the students using the Stanford Faculty Development Framework, which I'll show you in a second. Linear regression model, what they were trying to identify is the contributions of specific teaching behavior to something they called student growth. So at USHUS, they do a lot of pre-testing, and they have this incredible database, and then so they can measure student growth, and they had a definition of student growth, how much they grew over the clerkship. And here's a sobering fact that clinical teaching accounted for about 6% of variance in student performance. So most of the variance was preclinical GPA. But anyway, so clinical teaching counted. This is what I found interesting, is that these are the teaching behaviors that contributed most to student growth, again, dependent on the instrument they used, so the instrument they used it. But the really interesting thing, I think, was, so they were fostering active learning and facilitated learning. That means they showed them how to use resources, they showed them how to look up information. Here's a good article on pancreatitis. Here's a good website that you can go to look on how to do this physical exam maneuver. But anyway, one of the things that was really interesting is that the lower performing learners responded to different teaching behavior than the higher performing learners. In other words, the learners had different needs from their teachers depending on where they were on that learning spectrum. And I thought that's kind of an important thing to think about. Okay, Stanford Faculty Development Program on Clinical Teaching. This came out of Kelly Skeff's group, Kelly Skeff and Georgette Stratos. They've been doing this for 25 years. It's a program designed to enhance clinical teaching. It's a very, very well done program. They have a framework that organizes teaching into 7 categories. Each of those categories has 3 to 5 key components, and then they get even more specific with specific teaching behaviors. So they start out broad, big categories, then they get a little more specific, and then the teaching behaviors are very specific behaviors that enhance teaching in each of that category. So these are the 7 educational categories. I'm not going to go through that, but you can see what they are. And then the behaviors. So these are the behaviors. So if you want to be a good teacher, all you need to do is do these behaviors. So I'll give you a sec to look at them, and them, and them. All right, so 83 behaviors. So those are the behaviors that you have to learn. All right, so then I said, okay, well, maybe I'll ask my residents and my former chiefs and the current chiefs about what makes an effective teacher. And so they gave me this list of things, which I thought was interesting. And they're roughly in order of how frequently they were said. But you can see lots of different behaviors. So add these 8 behaviors to those 83. There's a little bit of overlap. So we're up to about 100 behaviors. So 100 behaviors to make you a good teacher. So there's a lot of things to put somebody into being a good teacher. All right, so Yogi died this week, and he's my favorite quote master. So far, I think I'm supposed to be a little clear on what makes a good teacher, but I'm probably muddling the waters. I never saw Yogi Berra play as a player, but I remember him as a coach. He was the coach for the Mets in 1973. And interesting, when we do our Stanford Faculty Development Series, one of the questions we start out with is, think about the best teacher you ever had in your life and what made that person a great teacher. So we get very specific. They have to think about a very specific person. And invariably, in a class of 8 to 10 people, 2 or 3 people pick a coach. They always pick a coach. They don't. I don't ask them to pick a coach. I don't say teacher or coach. They'll pick a coach. And we'll get back to that in a sec. But I think there's a good reason that people pick coaches. All right. So now I'm trying to get you a little more clarity back on track here. This is a concept that Lee Schulman, who was an educator, a PhD educator at Stanford, came up with. And the idea is that a good teacher, a great teacher, has content knowledge. He knows his topic. So let's say he's a physics teacher. He knows physics. He really understands physics. He has pedagogical knowledge. He knows how to design a lecture, how to give information, how to organize information. But most importantly, what makes him great is pedagogical content knowledge. He knows how to teach that topic to that group of learners. So he knows how to teach physics to a 11th grade student. He knows the things they struggle with, how to make things clear for them, how to give examples that work for them. And that might be a very different skill than you would need if you were teaching physics to a college class or teaching a graduate level physics. So those are different skills. And I think for clinician educators, this is an important thing because we're teaching a lot of different groups. And the best clinician educators are people that have pedagogical content knowledge. They know how to teach DKA to a third-year medical student. They know the things that trip up a third-year medical student. They know the right examples to give. They know how to go back and use the physiology that they've learned to help them learn. And that would be very different than the way they would teach it to a third-year resident. And so I think that's the best teachers really have pedagogical content knowledge. How do they get that? They get it by knowing their topic. They get it by experience, by knowing learners, seeing so many learners coming in at a third-year level. They create teaching scripts. You guys probably have heard that concept of teaching scripts. So I kind of have a teaching script that I when the third-year medical students come on and they say, oh, there's so many hypertension drugs, I don't know which one to use and how do you add them onto each other. So I have a little script that I use for that. That script would be very different if I was teaching a second-year resident, that knowledge. But those are what great teachers have. And it's a process of lifelong learning their subject, observing their learners, helping their learners work through different concepts. So that's an important thing. So that's a take-home one. I gave you one piece of information that's useful. Okay, so now to my view. What do I think? So in my opinion, the best clinical teachers are learner-centered and learning-centered. And I'm going to talk a few minutes about what I mean by that. the best teachers understand how they contribute to curricular goals. They know what the goal line is that they're trying to get people to, and they contribute to that. They may not be able to contribute to every one of those curricular goals, but they may say, you know what, one of the goals of this residency program is to teach people women's health, and I'm going to be the person that teaches women's health. That's not me, by the way. So I'm going to be the person that teaches women's health, and they know how to get them to that curricular goals. The best clinical teachers have lots of tools in their toolbox. They're flexible. They know how to do things. They keep adding tools. Just like you guys are here listening to this lecture, you're probably reflecting on your teaching and thinking about, hey, I'm going to try this differently. And then they think about ways to improve. Okay, so what do I mean by learner-centered teaching? So this is my view of what I'm trying to accomplish as a teacher. So my goal when I'm a teacher is to move people from being independent practitioner to independent practitioner, to get them to be an independent practitioner by the end of their residency program. Additionally, my goal is to get them to being a dependent learner to being an independent learner. So that's what I really want to accomplish, is to get them to be an independent learner also. So this is my primary goal and this is my secondary goal. And then when I'm teaching, I need to figure out where that learner is. Where are they on that spectrum? You know, somebody might be here, and then I need to get them to here. And so how do I know where they are? Well, some of it's experience, knowing where learners tend to be, but more of it is observing them, asking them questions, seeing how they interact. You know, I was on rounds the other day, and we were talking about pancreatitis with the team, and you know, it's early in the year, so this was the first pancreatitis patient a couple of the interns had seen, and they really knew how to diagnose it and how to initially treat it, but they knew nothing about, you know, complications, local complications, systemic complications. So I asked a few questions. It became clear they knew how to work it up and how to diagnose it. So my focus was on talking about complications. How do you identify complications? How do you determine who's likely to have complications? So my goal, I found him, let's say, here on pancreatitis, and I wanted to push him here. And I think the good teacher really creates a little bit of attention. I like to think of it as I put a rubber band around it, and then, you know, like if they're really far from the goal, that rubber band there should be a lot of tension stretching them towards the goal. And that doesn't necessarily mean to be bad tension, but there does need to be the idea that if you don't know much about hypertension and you're a second-year resident, I got to let you know that, and we got to get you moving along, further along that spectrum. I put these two in here. I'll give you an example of this. So these are two people in my clinic, and probably this is true in GMO too. They put a chief complaint in, and it just so happened over a 3-month period, I had 2 patients where the chief complaint was gynecomastia. So male patients with gynecomastia, and so one of my residents, she came in and she said, "Oh, Dr. Grau, I saw yesterday that the chief complaint was gynecomastia. I didn't know anything about gynecomastia, so I read a little bit about it, you know, and I have some questions for the guy. I've kind of reviewed this." So she was here. She didn't know much about gynecomastia, but she was a fairly independent learner. She had done a fair amount of work. The other resident, this is a couple months later, the other resident came in and said, gynecomastia. I see that's my patient. What do I do, Dr. Grau? What could be causing it? Now, like a fool, I looked and I saw the person was on, you know, spironolactone, and I'm like, well, you might want to think about medicines, which was a bad idea. I should have let her struggle with the case and then come back and let, you know, that would have made her learn better. But I had to be a show-off and show that I knew what I, you know, so anyway, a good teacher would have gotten them from here to here without doing that for them. But that's the idea. So when I reflected on that teacher, I'm like, I fumbled that one. But I knew a lot about that learner. I knew that she's still very, very dependent. She happens to be an early 3rd year, and this person happened to be an early 2nd year. So that's a problem. That's a problem, and that we've been working on that in the clinic since then. Anyway, so what are some learner-centered skills? Knowing where the learner is, we talked about that. Experience, observation, evaluation, questioning. Those are some of your skills that are going to allow you to know where that person is, know where you want to go, having goals, having objectives, and then helping them get there. There's a lot of different ways you can help them get there. Sometimes it's direct instruction. Sometimes it's giving them feedback. Sometimes it's motivating them. One of my learners, she just wouldn't come up with a plan, and it was just all confidence. It wasn't knowledge or anything like that. It was confidence. So that's a different, you know, now I'm dealing in the affective area. I got to motivate her, rather than teach her facts. But sometimes people would just say, well, just read more. But that wasn't her problem. But I had to kind of observe her and figure that out to get there. Okay, so then going back to those 83 Stanford behaviors, then you can kind of carve out the ones that are learner-centered. So these are some learner-centered behaviors, asking the learners for their goals. Boy, that's an easy way to figure out what they need to know. Just ask them what they need to know. That's usually pretty effective. Ask them to self-assess, have the learners help focus the session. Hey, what do you guys want to learn about in this session? Again, very learner-centered. I'm not going to go through all of these, but you get the idea. Okay, so you guys may not be able to read this, but what it says at the top here is, I taught Stripe about hyponatremia. And then it says here, it doesn't seem to me like Stripe knows how to evaluate hyponatremia. And he said, well, I said I taught him about hyponatremia. I didn't say he learned it. So anyway, excellent teachers are focused on learning, not on their teaching, not on how great their lecture on hyponatremia is, but how do I get the people to learn about hyponatremia? You guys have seen this probably before. This is kind of the schematic of how we learn. First, we got to listen, pay attention. The information has to come in, so you got to keep them stimulated, keep them motivated. Then it goes to working memory. You can hold about 3 to 5 concepts there. You can put more concepts there if you tell them stories and some of the other neat things that people have talked about with teaching. And then you put it into long-term memory. And this is complicated. Putting it into long-term memory, getting it out of long-term memory. They actually, when you put it into long-term memory, they hook it to things they already know. So hooking it to stuff that the basic scientists have taught them, teaching them about murmurs in the context of cardiac physiology. Much more likely for them to remember it and to be able to retrieve it when they need it. And then retrieval practice, practicing things over and over again. So the fact that the residents say, oh my gosh, this is our third PE that we've got this month, we're not going to learn anything. Well, the truth is they are going to learn a lot for their third PE. They just, because it's going to be in their memory and they're going to remember it better. Anyway, so these are the kinds of things you should be thinking about when you're trying to teach somebody. So these are learning-centered skills that have been shown to result in long-term memory. Sometimes they're different than what learners think are effective learning techniques. So sometimes learners think that by rereading the material, that's an effective way to learn. But we actually know from cognitive psychology that that's not an effective way to learn. So building on prior knowledge is key. Setting high standards. There's a lot of literature that if you set high standards, performance outcomes are better. And you just need to do that in a respectful way. Teach what the learner needs to know. We've talked a lot about that. Teach what they need to know at that point, and it's going to get in there. Focusing on concepts rather than facts. That long-term memory, they organize it best at concepts. So talking about inflammatory arthritis versus non-inflammatory arthritis, talking about the concepts and putting them into categories that deal with concepts, they learn much better that way. Having the learners meaningfully interact with the material. So if you're giving a talk on preoperative evaluation, you can just give that talk, or you can have them work through some cases and then talk about preoperative evaluation. When they meaningfully interact with the material, they learn it. The spiral learning model. So the spiral learning model, you guys probably don't know it, but you do it all the time, is the idea that you revisit the topic multiple times throughout the curriculum, but each time you visit it, it's at a higher level of complexity, a higher level of detail. And that takes advantage of a lot of cognitive psychology where people learn better if they've learned something before and if you come back to that topic and you keep bringing it at a higher level of complexity. So again, that's a real good model for us because we got a group of third-year students, an AI, an intern, and a senior resident. They are all at different levels of knowing about pancreatitis. But if you can teach the one group a little bit about the basics, but then get your other learners to teach on a higher level, you can kind of meet the needs of everybody at the same time, which is really hard to do. So, and then it's still a growth mindset. There's Carol Dweck. She's a good TED Talk to look at. She talks about growth mindset, the idea that intelligence is not a fixed variable, but intelligence is something that can be continually improved. The people that learn the best are people that have a growth mindset, where you say, gosh, you did a real good job because you worked hard. You've really improved your in-training exams, rather than saying, you're really smart. These in-training exams are great, you're excellent. That's more of a fixed mindset. Your intelligence is something like God-given versus a growth mindset where you're saying, we can move you, we can make you better. So this is a great book. I just put this up here because I just read this book, but it really talks about how people learn and what we've learned from cognitive psychology. It's about 250 pages, real easy to learn, and it's on your references. Okay, so I'll finish up with just my thoughts on improving as a clinical teacher. This isn't quite as evidence-based, but reflect on your teaching. So think about how you did. Like after I finish this lecture, I'm going to reflect on what I did better, what I did well, and what I need to do better. And I guarantee if you invite me back to talk again, I'll do a better job because I'll have reflected on it. Read your teaching evaluations and learn from them. That can be really frustrating because sometimes the students are unfair and it feels like they're hitting you hard. Most of them are pretty laudatory, so but don't concentrate on those ones. You're not going to learn anything from them. Concentrate on the ones where they've said something negative because almost always there's a kernel of truth in that. There's a little bit of truth. I remember one student, he was just really slow. This is when I was in the Air Force, just really slow. And I had this busy administrative job. I always had a meeting to go to after clinic. And he said, Dr. Grau never sat down and taught me anything. And it's because he was so slow that by the time he got done clinic, there was like no time to do anything. We just barely had time to do it. But I didn't. My fault was that I didn't, and I knew he was slow. And I knew we weren't going over things, but that's my fault. I needed to help him with his organizational skills and help him be quicker, and that was, so I learned from that I can't let these things go. I got to take care of him because he did have a bad learning experience because I didn't address the problem because I was even too busy to even talk to him about it. But again, you'll learn from your teaching evaluation, and having a framework like the Stanford Faculty Development is a good way to think about it. So you can think about, hey, boy, that teaching session went really well. What did I do well? Oh, well, I set a good learning climate. Here were some of the things I did. I made sure I knew all the learners' names and things like that. Learn about learning. We talked about that. So there's a lot of, the medical education journal always, the academic medicine journal always has articles on cognitive psychology. Dive into them. They're really kind of interesting because they'll almost always give you like, hey, I could do this a little differently. Like I learned the other day, remember my pre-op evaluation I talked about? I thought it was better to teach about preoperative evaluation and then have them work through cases. Actually, to get learning, it's better to do it the other way, to have them work on something that they don't know about, and then they're more likely to pay attention because now all of a sudden you've activated them and they're like, I got to know this. I couldn't work through this case at all. It's actually better to do it cognitive psychology-wise, better to do it the other way around. I thought that was interesting. Have a colleague observe you teach. And for this group, I would recommend that you volunteer to teach, to observe colleagues, because this is a group of people that has been doing this for a long time. And it really is valuable to do that. And then we talked about keep adding tools to your toolbox. All right. Hopefully. Sorry, I went a little longer than I thought. Anyway, I guess we'll take questions as a group now.
Absolutely. First